Hello, guys. I am recording a series of 3 videos for our nutrition content due to the fact that we have holidays on 2 Mondays in a row. So this is a lecture series for my class. It's first semester nursing. If you aren't in my class and you want to learn more about nutrition, obesity, and hydration, please feel free to watch these videos, but they are intended for my students, and I'm actually just at home recording on Zoom and wanting to make this good presentation for them because I want them to get the content, but this isn't my normal YouTube channel content. Okay, so we covered nutrition. Now we need to cover hydration, which is equally as important. Oh, sorry, that's my dog in the backyard, but I have to keep going, otherwise we'll never get through this presentation. So, hydration, drinking water, being hydrated, all of that, we know it's an uphill battle. Got to do it every day. So, what causes a fluid imbalance, deficit, or overload? We need to talk about that and how we're going to fix it for our patients. So let's first talk about our physical assessment. I hope you can't hear my dog too much. There's like construction going on next door. I'm just really having a rough time of it today. Okay, so mucus, let's start with our physical assessment, okay? Number one, our patient's mucous membrane. So our tongue, our teeth, our lips there, eyes, are they dry? Are they moist and pink and look like, if you go and look in the mirror right now, give yourself a big smile. You'll have shiny teeth, gums, they're pink, hydrated, your tongue is moist. That is what a mucous membrane with healthy, adequate fluid status looks like. A mucous membrane that does not have healthy, adequate fluid intake is something that you won't even believe if you've never seen it before, but it is like a smooth, plastic almost looking tongue with cracks in it sometimes, just dry, cracked lips, very dry. You'll know that your patient is dehydrated. Their skin is oftentimes dull and dry as well. We measure their input and output, which I'm going to talk to you a little bit more about in this presentation. We'll also do this in the lab. But we measure everything that they take in and everything that they put out liquid-wise in a 24-hour period of time. When you're working 12-hour shifts, you'll do it for your 12-hour shift. Okay, and I will go over what that entails in a bit here. We can do daily weights for our patient. This is the best indicator of kind of water weight loss, but it doesn't necessarily mean that your patient is dehydrated. So if you see a quiz question that asks about like, what's the best way to see if a patient is dehydrated, I wouldn't base it on daily weights because anyone out there knows you can weigh between 3 and 5 pounds different throughout a week. That doesn't necessarily mean you're fluid deficit, right? But it does mean that you're, holding on to fluid or not throughout the week. And then skin turgor. This is a term that you'll learn. It's a way to just quickly assess if a patient could be dehydrated or not. And you want to pinch their skin, and usually you should do it right here. I'm going to show you right here. You pinch it and it bounces back really rapidly. That means I have a good skin turgor. So I'm hydrated. And the reason why you want to check it on the sternum is because for some reason, the skin doesn't get affected by just like the aging as much. Because if you check the skin turgor on my finger, oh, it's going to just tent forever. You see that? So that doesn't really help me out. So you want to check it on the sternum. But if it remains tented, once you pinch the skin, if it stays in that pinched state, then that is a poor skin turgor. Okay. So what does a person with adequate hydration look like? Well, again, like I said in the other video, look around the classroom. Okay. None of us are severely dehydrated. We may not have the best hydration status, but For the most part, everyone's skin is nice and bouncy, and our mucous membranes are moist. We have normal vital signs. So our heart rate is within the 60-100 beats per minute. We have a stable weight. We have normal saliva and tearing. Mucous membranes are moist, and our normal perspiration or moisture on the skin. So I don't know if you've ever seen a dehydrated sick baby before, but if you have, they will be crying and no tears are coming out. And then you just know, like, oh, this baby's so dehydrated. If they're crying and the tears are flowing, then you know that they have, pretty adequate hydration, at least at that moment. So our skin turgor is brisk. Their thirst is satisfied, so they're not feeling thirsty. Although this isn't necessarily the best indicator either. It's on this slide, but once you get a little bit older, you sort of lose that thirst sensation. And so your thirst really can't be like the absolute indication that you're hydrated or not. But if you are thirsty, if you're feeling thirsty, already kind of in a dehydrated state, if you feel thirsty. Our urine output, we want our urine color to be pale, straw colored, yellow colored, and clear. Then we know that we are having some adequate hydration. Also, the rule of thumb is 30 mLs per hour is an indication that your patient has an adequate hydration status. And then a patient with good hydration status has soft formed stool, so they aren't constipated. Once our patients start to get dehydrated, they really get constipated, and you can watch all of that in my elimination video if you want. So what are some clinical manifestations of a patient with inadequate intake of hydration or water? So our vital signs will be affected. If you are dehydrated, your heart rate will increase because now you have an inadequate fluid volume, which is going to be a vascular fluid volume as well. And so it's going to take your heart twice as many beats per minute to pump that decreased fluid volume through the body. So your heart rate will go up to compensate for this. Your blood pressure will go down because you have inadequate cardiac output and preload. Preload you'll learn about in ICU, but it just means the amount of fluid going into the heart is inadequate. And so your blood pressure is going to be lower. And then on the slide here, it says postural hypotension, which is also known as orthostatic hypotension. Hopefully we'll be able to practice this in clinical, because what orthostatic hypotension means is that if your patient is laying down and you take their heart rate and their blood pressure, then you sit them and you get a certain number for that. So orthostatic hypotension is basically when a patient's blood pressure that you take, let's say it's 120/80 and they're laying down. And then when you sit them up and retake their blood pressure, the blood pressure drops. So the definition, when you look that up, is it drops 20 milligrams. It drops 20 milligrams of mercury with the change in posture. That can make people dizzy. It can make them prone to falling. So if you're getting your patient up out of bed and they have a decreased fluid status or they have inadequate fluid volume, they'll become very dizzy when they try to sit or stand. And that is kind of known as orthostatic hypotension. So their pulse will be weak and thready. If you've already done the vital signs lab, you felt everyone's pulse in class, and their pulse is nice and strong and steady and regular. A thready, weak pulse, you'll know it when you feel it, but it just feels like flitty, like little butterfly wings inside their radial artery. And then respiratories will be normal or slightly elevated. Again, if your patient is dehydrated and now their heart rate is up, which means that their heart is having to pump harder to get that decreased fluid volume circulating throughout the body, well, naturally the respiratory rate is going to go up too, because it needs to support the heart working harder. We'll have poor skin turgor. You'll have that tenting skin turgor when you pinch it on the sternum there. Mucous membranes will be dry. Their sputum, which is the mucus that they expel, will be very thick, very tenacious. And they may be thirsty, but like I was saying slide before, they may not notice that they're feeling thirsty. So their urine output may be decreased, and the urine color will also be darker, more concentrated, which makes sense. So even for yourself, check it out. If you're having a really good hydration day, you'll notice that your urine is light, clear, yellow straw. If you haven't had any water all day and you've been running around and you end up going to the bathroom, your urine is going to be pretty dark. So the color of our urine does tell us something about our hydration status. And then it'll make our patients very constipated, especially they're already in bed. Now they're dehydrated. All of that large intestine is going to absorb whatever fluid is in the body, and their stools are going to become very hard and hard to pass. So patients with an adequate hydration status, they're going to be possibly thirsty, restless, have a headache, unable to concentrate. They might have cold, clammy skin or dry skin. They'll have that weak pulse. Olguria is the term for urine output less than 30 mLs an hour. So they may have olguria. Monitor for their orthostatic blood pressure. You can do this one by sitting them up and asking them how they feel, but you can also take their blood pressure when they're laying down, sit them up, take it again. If their systolic drops more than 20, you know that they're positive for orthostatic hypotension and most likely dehydrated. Note the skin turgor and check and see if they're having any vomiting, nausea, if they've had diarrhea, which might be causing the dehydration in the first place, a fever, which can also cause dehydration, or diuretic therapy. And a diuretic is a medication that causes our patient to urinate frequently. It is usually used in heart failure patients to get rid of excess fluid. So those could actually be causing your patient to have dehydration. Okay, so what can we do to support our patient's hydration status? Let's say they're allowed to have things by mouth. They're allowed to drink, they're allowed to eat. We want to keep their water at their bedside full all the time. So when we get to the clinical setting, you'll see they'll always have a pitcher of water on their bedside table. You just, every time you want to fill it up, you want to pour them a cup of water and ask them to take a few sips for you. I have here the offer fluids of choice in between meals, and then obviously fluids during meals. And then it says here, force fluids. That was the old term. I don't like to use the word force fluids anymore. So I say encourage fluids. And by encouraging it, just be like, okay, every time I come in the room, you're going to take 2 sips of your water, just so that they can start to hydrate, because they might not feel the urge to drink. Control the environment in which they are in the hospital, because it can be really cold in there. It can be really hot. So you just want to make sure that they're at comfortable temperature, that they have blankets on if they need to, or take the blankets off if they're too hot. The elderly population tends to have difficulty with thermoregulation, so they can't control their body heat, and they sometimes don't even feel if their temperature is going up or their temperature is going down. So we need to monitor that for them. It's a classic thing to go into, you know, your 85-year-old grandma's house and have her bundled up with a jacket on and a sweater and the heater on when it's 90 degrees outside. That can lead to dehydration, obviously. If your patient is tube fed, you're going to add the water as needed to prevent constipation and normal urine output. We talk very much about tube feedings when we do our nasogastric tube skills lab, but just in case you're not watching this from my classroom setting, if you have a patient who has a tube feeding, normally there will be an order with the tube feeding to give free water at certain hourly intervals, or when you're flushing before and after giving medication. So just make sure that you do include that when you are taking care of a patient with tube feedings. You're going to monitor the daily weights, and you're going to monitor for olguria and anuria. Okay, take a second. What do those mean? Olguria, low urine output, less than 30 mLs per hour. anuria, A means absent, anuria means no urine output. Okay, an NCLEX question. Clinical assessment of dehydration would be confirmed if the nurse identified a 1 pound weight loss, engorged neck vessels, dry mucous membranes, or a full bounding radial pulse. Which one is it, guys? It's dry mucous membranes. Oops, I actually have a slide to show you that. Sorry. Dry mucous membranes. Because remember, a 1 pound weight loss, I gain like 3 pounds, lose 5 pounds in a day. So that's not adequate for hydration status necessarily. Okay, so let's talk about our intake and output. How do we record this? So you need to record during your 12-hour shift. Nowadays, we have electronic health records where when you do your rounds, you can document their intake. In the computer, it'll add it up for you over the course of the day. But if you don't work in a facility that has that, there's normally like a piece of paper taped onto the door or something where you jot down how much oral intake they had. So anything orally, you're going to document. You're going to document all the IV fluids that are going in, and you're not there yet since this is first semester for this class, but our IVs are set at a certain rate. So it'll be like, let's say 50 mLs an hour. So you know if the IV has been running all day long for 50 mLs every hour, you can add that up, add that into your intake. And then also the tube feedings will have usually an hourly rate. So you can add that up. And then the output is a little bit trickier because you're only going to measure urine emesis, wound drainage, and then your gastric tubes drainage. You don't measure stool unless it's watery diarrhea. So here I have a little tip on how you can measure certain things like ice chips. So ice chips, you're going to measure half the volume that you're giving. So if you have 200 mLs, 200 ml cup of ice chips, you're going to document 100 mLs of intake. And foods that tend to become liquid at room temperature, these are considered oral fluid intake. Okay, so if your patient eats 200 mLs of a beef stew, that would be considered food. But if they eat 200 milliliters of ice cream, that is a liquid intake. So know that for quiz questions and things like that. You don't measure pureed foods because even though it's pureed, it's technically a solid food. So the other things that we measure are our parental fluids. Parental fluids means going through the IV, like medications and maybe food. Total parental nutrition is when they're getting all of their nutrition via IV. So it'll be a formulation from the pharmacy in an IV bag, and usually they have a bag of lipids as well. That would be considered fluid intake and IV fluids. And then if we have anything catheter, tube irrigants, we're going to measure that as part of our intake too. I'm just going to leave that at that because when you get into your surgical rotation, you'll learn more about irrigation of wounds of the bladder and things like that, where you'll go more in depth with that, but that would be considered an intake. And then our output, I'm just going to repeat it: liquid feces, vomit, urine, tube drainage, and wound drainage. And you're probably thinking, what do you mean wound drainage? Well, you're going to see some wounds that have a wound vac that actually has a chamber where drainage is collecting. And sometimes it can be quite a lot of drainage. And then tube drainage, if you have any kind of like Jackson Pratt drain from a surgical incision or a chest tube, those types of drains are going to be included in your output. So here is a little table with some common measurements. Our usual styrofoam cup that we use in the hospital setting is 240 mLs. This one right here, let me get my little pen. This one. So that's the usual cup that we use in the hospital. There'll be water pitchers, and this is, you know, for me and my lecture here today, you'll want to double check with the facility that you're working in with what their measurements are. They'll have a little graph like this somewhere in the supply room so that you can see that. Yeah, so this is good to know. It wherever you do end up working, have this so that you can easily calculate. And then clearly, obviously, if your patient has a full 8-ounce cup of water and they drink half of it, you document that they drink half of it. You don't document that they drink the whole thing just because you set it down on their table. You have to make sure that you're documenting what they're actually taking in. Okay, so that's the end of the hydration section. Next, I'm going to do obesity. So check out that video next. And then I will also do a blood glucose metabolism quick video after that. So see you in the next one, guys.